Hello, and thank you for joining me today. My name is Annalisa Torres-Aquino, and I am the Director of Clinical Compliance for Aspen Therapy. Welcome to our educational session on ICD-10 training. After viewing this session, our audience members will demonstrate increased understanding of why specific and accurate ICD-10 coding is so important, improved comfort with coding basics, increased awareness of seventh character coding specifics and their impact on reimbursement, and familiarity with the diagnoses that drive case mix scoring. Why do we need more ICD-10 training? Under PDPM, reimbursement will be based on two main areas: the patient's clinical condition, defined by the ICD-10 codes that are selected, and the patient's functional status, outlined by Section GG scoring. By capturing the best codes and scores, we will be assisting the facility in receiving accurate and appropriate reimbursement for the services provided. When it comes to PDPM, ICD-10 codes correspond to the clinical categories that drive the case mix score for reimbursement. Nursing has 10 categories, PT and OT have 4 collapse categories, and speech therapy has 5 components that impact cost and reimbursement. This image here, taken from CMS website, shows how the clinical categories correlate to the collapsed PT and OT categories. For the speech therapy components, a number of different characteristics were considered that were predictive of increased speech therapy costs, including acute neurologic clinical classification, certain speech therapy comorbidities, the presence of a cognitive impairment, use of a mechanically altered diet, and presence of a swallowing disorder. It's important to note that if any of these items are noted during the screening or evaluation process, we must notify our facility MDS nurse before the initial ARD to ensure proper coding. Under the new payment system, specifics matter. Accurate coding is necessary to capture the best diagnoses for each patient and enable placement in the most appropriate clinical category. Unspecified codes will often result in no category placement and no reimbursement. An important fact for our clinicians to remember is that unspecified codes can be made specific by noting information we should know. For example, what limb is affected and on what side of the body. Consider this: coding of a femur neck fracture without mention of a specified part of the femur neck or the specific side of the body will result in a return to provider scenario and does not provide any reimbursement to the facility. Now consider this: coding a fracture of the head and neck of the right femur places your client in a non-surgical orthopedic, musculoskeletal orthopedic surgery category, and this does provide the facility with reimbursement. Here are some quick tips to consider for coding under PDPM. Codes that are listed as other are more often reimbursed than codes that are listed as unspecified. The medical management category typically results in the lowest reimbursement, and all case mix scores are determined by a combination of the patient's clinical condition and their functional score. Here are some important facts to remember as we transition to PDPM. It is critical to complete a thorough chart review for potentially relevant diagnoses. Sections I and Sections J of the MDS can impact the clinical category, and under PDPM, the reason for the skilled admission no longer needs to match the hospital diagnoses. The section of the MDS that pertains to your patient's active diagnoses over the last 7 days is Section I. Item number I-8000A is a fill-in-the-blank area for additional diagnoses that were not previously noted. I-8000 does not affect the clinical category case mix scoring for PT, OT, or speech. I-8000 can help identify speech therapy comorbidities and contribute to the non-therapy ancillary diagnoses documentation. Section I-20B, along with Section J, will drive the primary clinical category for PT, OT, and speech. Section I-20B is the primary diagnosis for the skilled admit and cannot contain a return to provider code. If you recall from previous slides, return to provider codes result in no reimbursement for the facility. As we have also discussed on previous slides, communication is important. Please communicate any diagnostic findings to MDS if they are not listed on the face sheet. Section J of the MDS pertains to health conditions. As you review the chart, be sure to scan for documentation about pain, falls, dyspnea, tobacco use, and depression. Also be on the lookout for major surgeries that took place within the past 100 days. And be sure to document your findings in your evaluation as well as communicate them to the MDS nurse. Communication of these findings could directly affect updates to the clinical category. When completing your chart review, be on the lookout for additional opportunities to capture impactful clinical conditions under the new system. When considering factors like speech comorbidities and non-therapy ancillaries, scan for specific diagnoses that indicate increased care and cost for the patient. The chart should be scrutinized for diagnoses that are related to your discipline, as well as any other clinically significant conditions that may pertain to non-therapy ancillaries, speech comorbidities, and any recent surgeries in order to maximize accurate reimbursement. This chart here, taken from CMS, lists some speech therapy comorbidities to be on the lookout for. If you see them while performing your chart review, please notify MDS. As we are completing our medical chart review, we need to be on the lookout for those items that can contribute to non-therapy ancillaries. CMS has provided a list of conditions. If you see any of these items, please document them and communicate your findings. As you can see from this chart, non-therapy ancillary conditions are assigned a certain number of points. These point values are added up and directly impact the case mix index. When considering the basics, the 7th character is important for coding accuracy. Fracture ICD-10 codes have slightly different 7th characters than other codes. For treatment diagnoses, include the main code indicating the need for therapy when possible and include the deficit code as appropriate. For example, code the femur fracture sequelae and the difficulty in walking. Sequelae codes frequently need deficit codes as well. Let's move on to more detailed discussion of 7th characters. Sequelae, represented by the letter S, is used to note complications or conditions that arise as a direct result of an injury. It describes the residual effects of the functional impact of the condition. There is no time frame for use of this term. Many of you may be more familiar with formally used terms, late effects or aftercare. Therapy will often use this character. Subsequent encounter, represented by the letter D, is used to describe encounters after the person has received active treatment of the injury and is receiving routine care during the healing or recovery phase. This includes encounters for cast removal or medication adjustments. This term indicates medical follow-up for an issue. Subsequent encounter is not often used by SNF therapists. Initial encounter, represented by the letter A, is used to describe the initial encounter for the injury or condition while the person is receiving active treatment for the injury. This is generally done in the emergency department or a doctor's office. It is not to be used to indicate therapy's first visit with a patient. When thinking of the 7th character, consider it from the patient's perspective. Us therapists are not their initial encounter for this issue. It is very important to understand the considerations that go into ICD-10 coding, but I want to take a moment to point out that all of our coding needs to be consistent with MDS, including the 7th characters. Moving on to aftercare or Z codes. Aftercare codes should not be used for aftercare of a condition such as injuries or poisonings, where 7th characters should be used to identify subsequent care. For example, if follow-up care is needed for an injury, it would be appropriate to assign S as the 7th character to represent sequelae. So based on those guidelines, if a surgery resulted from an injury, the original acute injury code would be used with the 7th character of S. In other words, We wouldn't use the Z code when a fracture has been surgically repaired. Instead, the acute fracture code would be used with the appropriate 7th character. It is important to note that Z codes may still be used with diseases like arthritis. So let's look at hip replacement as an example. We can look at hip replacement in 2 ways. Joint replacements due to illness, such as arthritis, will require 2 ICD-10 codes, a code for aftercare of the joint replacement, and a code for the identified joint indicating presence of a left artificial hip. The logic is, if they have arthritis and get a joint replacement, then they no longer have arthritis of the hip. Now for a hip replacement after injury. The femur fracture code for displaced intertrochanteric fracture of the right femur sequelae will be used, as well as the code indicating the presence of the artificial hip joint. Your MDS nurse may also choose to use one of the fall codes in the W series. Let's talk about weakness codes for a moment. M codes, like M62.81, relate to the disease of the musculoskeletal system and connective tissue. This weakness is due to conditions like rheumatoid arthritis and lupus that are non-neurological in nature. R53.81 is a chronic debility code. We need to code as specifically as possible, so we will not typically use this code if there is a diagnosis code that is better supportive of the weakness. R54 is for frailty and debility in old age. This may be more common code choice considering our population. Some things to be aware of. Some of our common treatment codes are return to provider codes. These codes cannot be used in I-20B as the primary reason for the skilled stay. Also, when possible, it is advised that speech chooses from the I-69 series of codes versus the R13 series. So for some final thoughts, take a minute to scroll through the list of related ICD-10 codes in Optima to familiarize yourself with what's there. If you see something, say something. We are all responsible for looking for accurate codes to reflect actual patient care and costs and provide accurate and fair reimbursement. And be as specific as possible. I would like to thank you for your time and attention during this presentation. If you have any facility-specific questions or concerns, please feel free to reach out to your FRC, area manager, or regional director. If you have any clinical questions, please feel free to email me at atorres@aspentherapy.net. Thank you very much.